Good afternoon, everyone. Thank you so much for taking time out of your busy fellows' schedules to join us, and welcome today to the 8th annual Focus on Fellows program. My name is Dr. Meltem Zeytinoglu, and I'll be moderating today's program. To share a little bit about myself, I am an assistant professor at the University of Chicago and the Adult Fellowship Program Director. I was a participant as a fellow in the very first Focus on Fellows program and have been thrilled to make the transition over the years following to the Early Career Advisory Group. And so I've sat in your seat and now I'm a fellowship program director. And so I am always eager to see those of you who are motivated and are enthusiastic about learning what the ADA can offer and teach you. I want to take a moment to note that none of this would be possible without the guidance of our ADA Early Career Advisory Group. So I want to thank all of my colleagues for their hard work in putting this program for you together today, as well as our outstanding staff who are also the heart and soul of this program. We are also very grateful for the support of the Leona M. and Harry B. Helmsley Charitable Trust, who have made this meeting a possibility. As a Focus on Fellows participant, you'll also become a member of the American Diabetes Association for free as well. And this provides even more opportunities to network and grow professionally. ADA membership includes a variety of professional member benefits, including meeting discounts, the Women's Interprofessional Network, which we call WIN ADA, various interest groups such as advocacy, public health, and a Diabetes Pro member forum, members only webinars for ongoing education beyond the scientific sessions, a member directory, the standards of medical care in diabetes, which if you aren't familiar with are really important, and you will be throughout your career, and to have the most update information on diabetes care, as well as Diabetes Pro Quarterly. The WIN ADA and public health interest groups will be hosting a free webinar and network event at the ADA's virtual scientific sessions. So these are really great opportunities to engage with others in the field and through your free ADA membership and scientific sessions registration. So you'll have access to a lot of great resources as an ADA professional member, and you'll receive information about membership following the sessions today. We're going to spend today's program by following the agenda that you see here on the screen. Please note that the presentations and workshops will include questions and answers. This is a really interactive program. So even though we're virtual, it's even more important actually for us to get to know each other. One of the neat things about the Focus on Fellows program, I can tell you from my own experience, is that some of the colleagues that I met during my own experience, I still am friends with, and we collaborate, and so it's really nice to network and get to know your other fellows, and Q&As and breakout sessions can help us really be interactive. Feel free to use the Q&A box in your control panel if you have any questions or comments throughout the presentations. You can let us know if you want to ask a question live by using the chat or raising your hand, which is located in the reactions tool on the dashboard. It could also be listed under more or options. And if you're having trouble finding it, just send us a private chat and we'll be very happy to help with this. We'll be answering hopefully all of your questions, but certainly within our tight program, we'll get to as many of them as we can. We're really excited about the program, and we hope that you all will enjoy and learn from it. So I am thrilled now to have the privilege of introducing Dr. Ruth Weinstock. Dr. Weinstock is the president of Medicine and Science for the American Diabetes Association. She is a SUNY Distinguished Service Professor and the Division Chief of Endocrinology, Diabetes, and Metabolism in the Department of Medicine at SUNY Upstate University in Syracuse, New York. Dr. Weinstock is also the medical director of the Clinical Research Unit and medical director of the Joslin Diabetes Center at the Upstate Medical University. Her research over the past 30 years has focused on the study of new approaches for the prevention and management of diabetes and its complications. Dr. Weinstock has over 200 publications and has served on the National Board of Directors at numerous committees of the American Diabetes Association over the past 25 years. Thank you, Dr. Weinstock, for joining us today.
Well, thank you. It's really a pleasure to be here. And it is really my great pleasure to welcome all of you to this Focus on Fellows program. Working with fellows is really one of the most important and rewarding parts of what I do. You are our future, and we want to do all we can to assist you to transition successfully to the next stage of your career, whether it be academia, clinical practice, research, teaching, public health, industry, combinations of these or other pathways, and if at any time in the future you decide to change directions and take a different path. We trust that the information you obtain and the interactions and experiences you have through ADA with your peers, as well as with more senior experienced endocrinologists and other professionals from all over the world, will be helpful and rewarding for you. I joined the ADA as a fellow, and it's been my professional home ever since. The volunteer work I've done with ADA has been enriching and extremely gratifying. Many of the people I have met through the many years at ADA have become trusted colleagues, and they also have become good friends and have been of great support to me and have inspired me and contributed and enhanced my professional development. I sincerely hope you experience the same and that you find these sessions worthwhile, stimulating, motivating, and fun, and that they are just the beginning of your involvement with ADA. I encourage you to explore the ADA website, diabetes.org. You'll find the standards of care there, which are updated periodically throughout the year, and other important information about ongoing initiatives and programs at ADA. For example, our advocacy efforts, which include much work making insulin affordable, available, and easier to prescribe, as well as trying to increase access to other diabetes supplies, medications, and devices for all people with diabetes. So please take advantage of the professional membership, including the webcasts, podcasts, discounted meeting registration fees, our journals, Diabetes Care, Diabetes, Clinical Diabetes, Diabetes Spectrum, our compendia, our patient education library, and other resources that you'll find on the website. In addition, we have, and we will have more later this year, RFAs for research funding that specifically target junior faculty. We really want to help you succeed. And if you have any additional ideas on ways in which we can meet your needs, please feel free to email me. I'd love to hear from you. So enjoy the meeting, and I sincerely hope to see you in person at future ADA meetings. Thank you.
Thank you so much, Dr. Weinstock, and we really appreciate your enthusiasm with the fellows. I'm thrilled next to welcome Dr. Robert Gabay. Dr. Gabay joins us as the ADA's Chief Science and Medical Officer. And he leads the ADA's efforts to drive discovery and within the world of diabetes research, care, and prevention. Previously, Dr. Gabay served as the Chief Medical Officer and Senior Vice President at Joslin Diabetes Center, as well as Associate Professor at Harvard Medical School. At Joslin, he oversaw the care of over 25,000 patients with diabetes, as well as the education and care programs that Joslin delivers nationally and internationally. We are so excited to have Dr. Gabay presenting today on the future of diabetes. With that said, let's go ahead and get started. Welcome.
Thank you, and welcome everybody. So great to have you joining us, and I echo Dr. Weinstock's comments that really the future of diabetes is you. It's not old people like me. It's going to be what you do in your lifetimes. And this program is one way that the American Diabetes Association is reaching out to you to encourage you, to guide you, to provide mentorship. And we welcome your feedback on how we could best do that. So I'm thrilled to be here. And I think we're going to have a little dialogue, right? To make this a little more interesting. And can we throw out questions to them to sort of...
We sure can. This is interactive. And again, this is a great way for us to get to know each other and for the fellows to get to know each other. So do you want to start with a question and sort of wake everyone up this afternoon if they aren't already?
Yeah, let's do that. Let's see if people are tuning in, if they're paying attention, or are you checking your emails? And so I will flip the question that I'm supposed to answer to all of you. And I will ask you, what do you think is going to be the big change in diabetes in the future? Where do you think it's headed? And then we'll have some dialogue around that as well. But curious, throw in your comments and let's see what you think.
And feel free to raise your hands as our producer Gil mentions, unmute yourselves. And if you'd like, certainly you can use the chat if you don't want to ask out loud. So Chelsea, thank you for mentioning your interest in your enthusiasm about advances in diabetes technology, a glucagon system for type 1 diabetes, and then with the closed loops. This is from Molly as well. Closed loop bihormonal with the glucagon and insulin. Everyone is so enthusiastic. We're just keeping up tepalizumab, new oral medications, more about closed loops, and again, more about prevention of the progression of type 1 diabetes. So, Dr. Gabay, what are your thoughts? So we are really at an exciting frontier for our fellows. They have a lot of new things to lean on. Oral insulin.
Yes, I agree. I think this is probably the most exciting time. I've been in the diabetes world all my career, and wow, what we're about to see, and already have seen some glimpses of, as folks have mentioned, about moving towards automated insulin delivery. A decade ago, nobody really thought that would happen. 2 decades ago, they thought it was going to happen in 5 years. So things keep changing. I think that is certainly going to be part of it. The big question there, and we'll get into this, is something we're really concerned about at ADA, and that's equity. So, yep, these things become available, but who gets them? Does everybody get them? That certainly hasn't been the way it's been so far. And so I think that's going to be hopefully an area of focus nationally, internationally, and certainly it's a big focus from all of us at ADA.
I'm really glad to hear you mention that. Just as you said, it's great when we have all these discoveries, but enhancing access to them. And one of our fellow colleagues here talked about also cost of medications. And so can you tell us a little bit about what the ADA, what efforts are already in place or planned for addressing some of these disparities?
Yeah, very much so. So one of the things, as we look at what the pandemic has taught us, it has in a number of things, but one of the things is it's been a magnifier, and what it is magnified is some long-term problems that we've had. We've seen the demonstration of the problems with public health system and how that needs to be invested in. But another big one has been the incredible health disparities that exist in this country, and it's time to do something about it. And we at ADA have really taken a strong stand here. I encourage everybody to go to our website. There is Health Equity Now. There is a compelling video that talks about why health equity. We all know the huge disparities that exist in diabetes, but if we solve it for diabetes, we will largely be mapping out what happens for other diseases as well. And I think that's really the exciting opportunity. The other thing you'll find there is a health equity bill of rights. And that's really a credo that we are looking to follow. And it has things like everybody should have access to healthy food. Everybody should have access to the technology that will allow them to manage their diabetes effectively. Everybody should have access to the medications they need to take good care of their diabetes. And so that's all of those are areas we're really leaning in strongly and advocating for in a lot of different ways.
That's really fantastic. I think one of the things we struggle with is the burden of diabetes in our population. But this is where we can turn that challenge into being, because of the burden and because of the ways that we can address these disparities, we can really be a model for other chronic diseases and conditions as well. That's fantastic. And for our fellows interested, there are all sorts of interest groups, as we mentioned. There are in advocacy and disparities, and you can certainly get involved in those even at the fellow stage, and we can share some of those resources with you. You mentioned,
and in fact, I'll just put a quick plug and say, for those of you that, I remember when I was a fellow and I was a little bit shy to sort of engage in these kinds of things. The interest groups are a wonderful forum where you can throw out a question. You could start by just following it, and there are, regular feeds of information from the famous people whose papers you read to fellows. And you can all have a voice and be part of a community. This is something we've done over the last few years, and I really encourage you as a way to start dipping your toe into the world, because we are just this wonderful collective group of people that are all committed to the same kinds of things, and it's through connections with each other that your careers will blossom. Who knows who you will connect with? They may give you a job if you're looking for a job. Any of those kinds of things are possible. So I very much encourage engaging in the interest groups, finding the ones that, are you're an islet cell biology person. Yep, we've got one for that. You name it, we got it.
Thank you so much. And that's a really great point. And what's, as we transition into discussing the pandemic a little and COVID-19, I remember the breadth of knowledge, and there was a COVID-19 group, and we were getting really nice, for very up-to-date volumes of information. And I have to say, it was exciting to see that fellows were driving a lot of this, being on the wards and seeing those patients. And so tell us a little bit about your experience overseeing a lot of what was going on in our challenges with the pandemic.
Yeah, I think that, we all and all of you really were on the front lines, much more than some of us. And you have seen a transformation in healthcare in a way that, really unprecedented, I would say, in any other period of time. So I one of the things that, when I reflect back on the pandemic, it has been an accelerant for change. And, for those of you that were involved in clinical care and research, when it hit, wow, did we change, and did we change quickly? Like, we all talked about telemedicine for how long? It's been a decade or more. Dr. Weinstock did groundbreaking work even before that on telemedicine, but it was never prime time. And then in the matter of 2 weeks, I can tell you, I was still at Joslin at the time when things first really started happening in March a year and a half ago. And I'll never forget. I was in my office. There was a knock on the door, and I opened the door, and we found out that we had our first staff member test positive for COVID. And that's when we knew, holy crap, we need to like lock this place down. We need to do all of our care remotely. And in the matter of, and this is not unique to Jocelyn, all of you have seen this, in the matter of 2 weeks, we did what normally would have taken 2 years to retool everything. How are people going to send their blood glucoses? What are the educators going to do? How do the vaccine, everything, all the details. So it, in an interesting way, it showed us that if we really want to and have to change, healthcare could change pretty darn quick.
And there's been a lot that we've been able to do with the ability to upload continuous glucose and insulin pump data, for example. And certainly this has improved access in many ways for a lot of our patients. I always found it interesting too that more family members would engage because now they're at home and they're available. They don't have to worry about coming in. And so tell us how ADA envisions telemedicine working in parallel with in-person visits, where we do need to see the patient and examine them as well sometimes.
Yeah, I think they're complementary. So one of the things that we advocated very early on in the pandemic to make sure that telemedicine was reimbursed, but then a few months ago pushing to make sure that they didn't roll that back. And we'll continue to fight to maintain access to telemedicine because we think it's here to stay. It's not a replacement. That's not the goal. But for exactly the reasons you said, it allows greater access. It might allow more frequent touches. I think you've all probably had the experience of a patient not sure what medicine they're on and literally going and pulling out the bottle and checking, whereas in the old days, we would just call me and tell me what it is, and that never quite worked out. So I really think it is here to stay. The other interesting piece that has accelerated is digital health. So as you all know, there are many companies out there that are offering a variety of services to patients. Again, not a replacement for what we all do, but honestly, where they do a good job and we historically have not, is the sort of between visit care. Like we see them and we do, you all do a great job, but then you don't see them until whenever they next come, and in between, if they reach out to you, yes, but we tend not to reach out to them. And so I do think, it's building this ecosystem that we now realize telemedicine is a critical part of. Digital health will increasingly be a part of. The ability to transmit data, as you said, technology, glucose uploads, all of that is all part of the answer. And I think we'll be here to stay, and it'll be part of the way you all practice diabetes care.
It's a really optimistic vision. I think, the image that I was thinking of is, this has happened to me countless times, and I'm sure many of you, where you prescribe a patient, it's not covered, and they wait 3 months until your next visit with them, and nothing has changed. And so having this sort of bridge and this care network, I think will really help us. Let's transition a little more to the roles of discovery in translational and basic research. And, some of our fellows here are interested in precision medicine. And so can you tell us a little bit about that?
Yes. An area over the last 3 or 4 years that the ADA has really been leaning into is this concept of precision medicine and diabetes. And in fact, we had, some of you may have participated a few months ago in a global meeting with thousands of people. And again, this is the beauty of being able to do things virtually around precision medicine. And the idea being, we have unprecedented ability to gather and analyze big data, whether that is genomic data, metabolomics, or behavioral information from our phones, from our, and again, there are privacy issues. I understand all of that. But imagine the ability to have the right treatment for the right patient at the right time, and really know, for example, for some of the folks that are probably involved in some of this research. We talk about type 2 diabetes as one disease, but we know it's not one disease. There are many different pathophysiologies, and we just sort of do the same treatment, right? Because we can't really figure out, is this more an insulin secretory issue? Is this more an insulin resistance issue? Is it a gut issue? Where are the lesions? But that is within reach. The technology now has allowed us to answer those kinds of questions, and that's really the work that we're excited about around precision medicine. So stay tuned. Probably later this year for potential funding opportunities in that area for research, because we do think this is an important area for ADA to invest in.
That's great. Thank you. It's an exciting road to look ahead to. We have a lot of pediatric colleagues as well here, fellows, and we know about the disheartening rates of type 2 diabetes and obesity in children, and they're interested in discoveries for children. What is the ADA pediatric discovery pathway right now?
So there are a number of things. First, I'll just say on the type 1 side, when we think about the future of diabetes, medications like teplizumab being close to FDA approval, and we provided FDA commentary on that, because we do believe that there's a lot to be figured out. But that said, we are really on the cusp of being able to, at a minimum, delay the development of type 1 diabetes. And that, again, is something that, for those of us that have been in the field and following TrialNet for 20 plus years, this is a historic moment in the world of type 1 diabetes. On the type 2 side, I think, we're really, in terms of prevention in children in particular, I think we're really at the point of needed discovery and research, because we're not quite sure how to do that. We know the DPP for adults, but we're not quite sure the best way to do that for children. We know that it has to be a family sort of thing. And so this is an area we also are interested in investing in research to try to figure out. And let me say that the way that ADA supports research is a few different ways. One is direct dollars that we may offer through the funding that we're able to solicit in terms of funding research. But another big area is advocacy. And so we have people on Capitol Hill that are literally knocking on the doors of Congress folks and advocating for the importance of research in many of these areas. And the good news is that the climate has been quite good for that, and we feel actually quite good about having some good increases in funding, which I think will really make a big difference.
Absolutely. And adding to that, networking as well, as you mentioned to earlier, from the interest groups and during the scientific sessions. We've got many other questions we could ask you, but I want to give you a chance. You've been telling us a lot. So do you have another question for our fellows?
Oh, yeah. So I do. I'm curious on a scale of 1 to 10, maybe. How optimistic are you? Like, where, I'm trying to imagine what you are in your shoes. You went through fellowship or early career stuff during a pandemic. We're hopefully coming to the other side. So how optimistic are you about the progress in diabetes and the next 5 to 10 years on a scale of 1 to 10? I think that would be fun.
That's a really good question. And you all can respond in the chat. Perfect. Thank you, Gil. Listening to you and Dr. Weinstock, it is so optimistic. And we know that that's what the ADA is here for. So good. I think that's being projected. But It's okay. We can acknowledge that on a day-to-day basis, there's a lot of challenges we face with diabetes. And, as a program director, I like to prepare my fellows to know that the hard things too. And so
Yes.
I love that you're so optimistic. But Amanda, you mentioned something about access to diagnosis. Can you clarify a little bit more? Do you mean access to therapies, or feel free to type it in the chat. Telehealth is an exciting thing. So we've got a lot of young, enthusiastic fellows here.
Great. Can I throw a follow-up question? So you're generally optimistic about your about the future of diabetes. How about your career? What how do the job prospects look to you as you're all many of you at that stage? Yeah, I'm curious, because this is helpful feedback for us, because we really are invested in your success, and that largely is why we do this program, but want to get a sense from your end.
And maybe as a sort of complement to that, what sort of career path, just so we can get to know you a little better, private practice, academic, full clinical, some research, or all research, of course. And Amanda, yes, it's a very, thank you for clarifying. There are, especially in certain areas, certain regions, especially, we have patients who have very limited access to chronic disease care. And so, I can definitely see where, if you're in one of those areas as you are, that would be something that really we need to work on. And that's where things like telehealth may come in as we're waiting. Dr. Gabay, I don't know if you have any comments on that.
Well, I agree. I think telehealth is one effective way to address that. I also think our roles will include more of helping the rest of the healthcare team to provide for people. So, for better or worse, there are just not enough of us as endocrinologists to be able to address the number of people with diabetes. And so the answer, even if you doubled the number, and right now, to be not optimistic, there aren't enough applicants to double the numbers, right? Like, we wouldn't fill the match if we doubled the number of slots. Not that we could do that. So really the answer is, how can we, with our specialized knowledge, leverage that across a population? We don't need to take care of all of them. We'll take care of some of them. But how can we help our colleagues do a better job? And I think that's part of the answer, and even more so in underserved areas where, yes, telemedicine will give them access, but if you do the math of the number of people like us that there are, and the number of people with diabetes, and you say we work 24 hours a day, 7 days a week, we still can't fill the gap. So it's going to involve our colleagues and this idea of team-based care. But we have this special knowledge and ability, and we need to leverage that and be rewarded, to be fair, for leveraging that across the population.
Absolutely. And Almira and Reem, excellent points, educating residents and students in the community. The ADA actually has a wonderful program for primary care providers and the standards of care. A lot of our primary care colleagues refer to that as well. And so you can be an ambassador for that by knowing those guidelines, knowing that they come out. You can really kind of help your colleagues know where to turn, of course, in addition to working with you. In the side chat, please encourage you to ask any questions for Dr. Gabay. In the meantime, while we're waiting for some questions, is there any specific career advice you have for our group?
Wow. Well, we have a mixed group here, so I might sort of break this down a little bit. on the clinical side, you know, for better or worse, the world is your oyster. You know, everybody needs an endocrinologist, and so pick what's best. You're a little bit in the driver's seat there, and so you know there are obviously a lot of family and other considerations and geography, but feel free to negotiate a little bit. And I know there are sessions in Focus on Fellows that'll arm you a little bit better. You know, on the research side, you know, I think it, you know, as you all know, it's a little bit more challenging. I think mentorship is critically important, and that's true in the clinical side as well. Identifying good mentors, whether they are the person you're working for, sure, but people that you don't work for, even more valuable in a sense, because you know they don't have any skin in the game, and they have, you know, identifying those mentors and yeah, I think that's really across everything. Um, and what I think makes a good mentor is somebody, you know, knowledgeable, reasonable, and that they clearly have your best interest. So it doesn't mean that they're always going to cheer you on and agree with you. They may disagree with you. But if you know that they have your best interest in mind and there's no agenda, then that, you know, I've been fortunate to have just incredible mentors, and that, you know, is, and I think if you speak to, you know, all of the senior people out there, everybody's got that kind of story. It really is about mentorship, and the beauty is you'll someday get a chance to pay back to the next generation, you know, and that's why we do what we do. Dr. Weinstock said that at the beginning. It's one of the most enjoyable things we do, because we can never pay back the people that did for us. We do for you.
Well, I can't echo that enough, and I appreciate that. And I've seen your mentorship, and as you mentioned, one thing I want to remind our fellows is just be your own advocate. Don't be shy about approaching people. You know, if somebody's busy, they'll tell you no, and that's it. But for most of us, it's really a pleasure, and we gain a lot out of it too. So it's really, you know, even the sort of big people that you can't approach. You know, and the other thing is sometimes if they can't mentor you directly, they'll know someone else who can. And so please be your own advocate. You know, we
very true. I think that I'll put a pin in that. Yeah. Be a little pushy. It's okay.
Yeah.
You know, no one's going to do it for you, and it's okay. And yeah, absolutely. Get a little out of your comfort zone. It's worth it.
Thank you so much. And so we have 1 minute left, and I want to ask you in 45 seconds, do you have any advice about the scientific sessions? It's a big program, so much information. But how should fellows approach it?
Yeah, it is the most, I mean, it's everything, right? It's everything. And so in that way, it can be a bit overwhelming. You know, I would look at the program a little bit as, what do you know you're interested in? And sometimes the things you know very little about can be the most rewarding, because you can learn something about an area you're not familiar with. I probably shouldn't say this, but I will anyway. You know, one of the nice things about being virtual is it's very easy to like pop around. And so, you know, go to a session that you may not know that much about. At least the introduction, you'll learn a little bit about that field. And then, you know, maybe when they get deeper in and you're not interested, jump to something else. But take advantage of that wealth of information. And, you know, whether it is in the clinical arena where there'll be announcements of landmark trials that will be shared, as well as wonderful reviews of the science. So, you know, the interrelationship between kidney disease, heart disease, and diabetes. You've got experts just summarizing all the evidence and all of that in one session. Like, you don't have to read all those studies. I mean, not saying you shouldn't, you should read all the studies, but it's that kind of stuff that if you're strategic, so spend some time before the meeting to plot out what interests you, and again, pick some things that you don't know that much about, because it's a great opportunity, low risk, to learn about it.
Thank you so much. We've covered so much. We could make a whole day out of this conversation. And I just want to share with the fellows that Dr. Gabay is a member of the Early Career Advisory Group, and year after year contributes to this. And so we're so grateful for your wealth of knowledge and enthusiasm. And we look forward to the fellows interacting with you again in the future. Thank you so much for your time today.
Very much. Thank you. And thanks to all of you for being part of this. And I know this year we won't be able to see each other in person, but you'll find that this session is very interactive. So take advantage of the chat. Say hi. I'll be on like all sorts of sessions. And I look forward to seeing you all in New Orleans next year. Thanks
a lot. Have a great day. I want to make a quick side note here that we did not build in because we have so much we want to cover and discuss with you. We don't have any formal breaks. Feel free, of course, as you need to step aside. But we're going to go right ahead to our next session. And thank you again to those that have joined a little bit later for joining the program. In case you didn't get to meet me earlier, I'm Dr. Meltem Zeytinoglu. I'm an assistant professor and the Adult Fellowship Program Director at the University of Chicago. And I've been involved with this program. This is the 8th annual from the first year on. I'm now thrilled to introduce our three panelists today, three professionals who bring unique perspectives to our discussion about diabetes science and healthcare. Welcome to Dr. Lisa Duran. Dr. Duran is an endocrinologist, board certified as well in obesity medicine, with an expertise in all aspects of endocrinology. She's co-founder of Pink Coat MD, a safe professional community supporting the emotional well-being of women physicians. Dr. Duran earned her bachelor's degree at Brown University and her medical degree as well at Brown Medical School. There, she was awarded a one-year fellowship at the Joslin Diabetes Center with Harvard Medical School to introduce to further her interest in diabetes. She went on to complete internal medicine residency at Santa Clara Valley Medical Center, an affiliate of Stanford, in her hometown, San Jose, California, and was the recipient of the Bender's Fellowship supporting diabetes research and care for underserved communities. After finishing her fellowship, she returned to the Bay Area, where she practices clinical endocrinology at the John Muir Medical Group, affiliate of the UCSF Medical Center, and she served as chair of the Northern California ADA. Next, I'd also like to introduce Dr. Erin Neinstein, Associate Professor of Medicine at UCSF, leading the Digital Patient Experience team at the UCSF Center for Digital Health Innovation. Dr. Neinstein is also the VP of Digital Health at UCSF Health. His digital health resume spans leading UCSF's ambulatory Epic electronic health record implementation development, as well as deployment of numerous digital health solutions, transforming digital patient experience and virtual care delivery across UCSF, research and advocacy, and advancing U.S. health policy, federal health policy, and operability and patient data access, as well as co-founding of Tide Pool, a nonprofit creating open source software to empower people with diabetes. Dr. Neinstein is an inaugural inductee as a fellow of the American Informatics Association, board certified in endocrinology, clinical informatics, and internal medicine. He maintains an active clinical practice focused on the care of people with diabetes and was named by Marin Magazine to the top 2020 Bay Area doctors list. And finally, I'd like to welcome Dr. Janet Mcgill. Dr. Mcgill is a professor of medicine in the Division of Endocrinology, Metabolism, and Lipid Research at Washington University School of Medicine, and attending physician at Barnes Jewish Hospital in St. Louis, Missouri. She is currently the principal investigator of the NIH-funded GRADE study and insulin-only bionic pancreas pivotal trial. Dr. Mcgill has conducted over 220 clinical trials in type 1 and type 2 diabetes, studying new treatments and complications such as hypertension, hyperlipidemia, nephropathy, neuropathy, and retinopathy. She was the principal investigator of the NIH-funded PEARL study preventing early renal loss in type 1 diabetes, and a CGM sub-study, also the recently published WISDOM study. She led the Washington University site for the Type 1 Diabetes Exchange Clinic Registry and was the PI for several Type 1 Diabetes Exchange trials and registry studies. Dr. Mcgill has served on steering committees and data safety monitoring boards for long-term outcome studies. Welcome to our group, and thank you so much for joining us today. I want to give you each a moment to say hello and ask any questions you have of our fellows for them to answer in the chat, and then we'll sort of have a conversation together about career paths. We'll start with Dr. Duran.
Sure. Hi, everyone. My name is Lisa Duran. I'd like to thank the ADA for inviting me on this wonderful fellows program. I actually didn't have this opportunity when I was a fellow, and so I'm really thrilled to be here to speak to you all about my experience in clinical practice. Practicing for close to 10 years now. I'm in my 8th year in community practice, where I see close to 100 patients a day, mostly diabetes. And I'm just really excited to share with everyone my insights and personal experiences being an endocrinologist and taking care of a lot of patients. And I guess my question for the audience is, I'd love to hear in the chat box who is, maybe you can give me a sense of what you're planning to do after fellowship. Are you planning to go into community practice? Are you planning to stay an academic? Are you planning to do research? I'd love to learn a little more about your interests.
Thank you so much. That'll really help us tailor our discussion too. And Dr. Neinstein, tell us a little bit as well about your thoughts.
You're on mute.
There we go. Sorry, I muted myself. It didn't let me unmute. Really nice to be with everybody. Appreciate the invitation. As Louisa said, I feel like when I was a fellow, didn't have this kind of opportunity for really learning about all of the different types of career opportunities that are available. I think it's very easy when you're training in an academic environment to be exposed to only a very small amount of what's out there in the world in terms of opportunities. And so would love to, engage in the dialogue here about the full spectrum of opportunities that are out there. My path, as was introduced, was really coming up through informatics and implementing our electronic health record, some entrepreneurial time developing a digital health nonprofit company, and now leading our digital health teams at UCSF. And I think what I would love to understand from you all, and Bob sort of started this conversation in the last segment, is thinking about not what the jobs were in diabetes care 10 years ago, but what do you see as the jobs that there will be in diabetes care 10 years from now? And how are you all thinking about what are the types of jobs that might not exist today that you hope will exist when you're 5 or 10 years into your career?
Fantastic. Thank you so much. And so we are seeing a very nice mix. A lot of our colleagues are interested in academic medicine, although I'm happy to see some as well in community practice and FHQCs. And of course, physician scientists as well, which is a great transition also to Dr. Mcgill. Welcome, Dr. Mcgill.
So thank you for the invitation to be here. It's always fun to talk about things that you've enjoyed doing for a long, long time. And I see questions in the chat about how to have a hybrid career. And I want to tell you that that's what many of our careers look like. They're really they're hybrids. So I have clinics, I take care of patients, and then it just happened. I was asked to join the faculty a long time ago to work on the DCCT, and that morphed to other studies. And then it just sort of mushroomed a little bit. And I did a lot of studies with very good coordinators, very good staff people. So I think, first of all, I would use time in your fellowship to get to know your faculty, find out what they have done and how they've done it. And you don't always have as much time with these discussions as you might like. So use the people you've got. You know, go talk to people that are very right there with you. What are they doing? You should PubMed every one of your faculty. Have all of you done that? Do you know what their interests are, what their strengths are, what kinds of groups they associate with, and are any of your interests aligned with what they are doing? And if so, how to utilize fellowship, but then how to learn how to do that in practice. And whether the practice is an academic center and you want to use a completely interesting skill like Erin, you know, you happen to be good at informatics, which is not my skill. I was once told by my son to, Mom, stop calling me. You got to learn this stuff. So I did learn it. But so if you have a particular skill like Erin, well, go for it. If you're good at statistics, or if you're good at writing, or if you're good at journalism, or if you are simply good at or really have a passion for some aspect of diabetes care, like diabetes and pregnancy, or technology, type 1 diabetes, or obesity, well, follow those passions and become an expert, and then and then just kind of go for it. Most of us have had to carve our places. You know, we had to do carve outs. There isn't another person exactly like me at WashU. And there won't be another person exactly like Erin at USC. And Louisa has carved out her practice, you know, and developed it in the way that, you know, the way she wants to see it happen. So you got to make it happen.
Thank you, Dr. McGill. That's great advice. I think, again, that theme of being your own advocate, you may end up paving the road that isn't there, and finding the right mentors that can help along the way. So I want to kind of, this is a question for any one of you, all of you, regardless of what you're doing, do wear multiple hats. And what's one of the challenging parts of that? That you've learned to kind of manage? What's some advice for that for our fellows as you move on in your career, especially?
I'll take a stab at that because I think this is a really important point that I wish was emphasized to me earlier as I was graduating from training and entering real world practice. I love that the theme on our panel is that we do wear multiple hats, and we have, as Dr. McGill talked about, created hybrid careers. We've become advocates. Erin and I have invested and drank the Silicon Valley Kool-Aid and have gone into our entrepreneurial paths to start, new organizations to really advance medicine and healthcare. And, I think the bottom line is that we really need to be changing the conversation from, all of the different personas we have to just the idea that we're integrating work and life now. And it's an integration of, our person, our spirit, the gifts that we have, the talents that we bring to the world. And so, when you choose to do things, just remember you're fully integrated as a person. So I get a lot of questions about how am I doing it at all, right? How am I chairing a community leadership board? How am I having full-time clinical practicing, tons of patients as an endocrinologist, mother of 3 kids, starting a company, and all of these things. And I think at the bottom line, you have to remember what you love to do ultimately drives who you are. So I am the best person at home when I am working full-time as a clinical endocrinologist. I'm the best clinical endocrinologist when I am working my creative mind, starting an entrepreneurial endeavor. I am the best friend when I am fueling, my life at home and being a mom. So I think if we can think about integrating everything together as one person, whether it's academic research, community, doing digital technology, all of those things, all of that feeds into your true self and your energy. And that's going to drive you forward in whatever you do. And that's going to help you advocate for the things that you want to accomplish in your lifetime.
I couldn't agree more. I think finding the synergies and integrating who you are is so critical. It's sometimes can feel like early in your career that, every opportunity is a great one. You'll find very quickly that you have many, many more opportunities than you know what to do with. And so finding the places where there are synergies and where you're taking on one thing that's serving multiple purposes for you, I think is really critical. So totally agree with Louisa's point about integration.
Thank you. And let's transition a little more to your unique individual path. So Dr. Neinstein, tell us for we're talking a lot about telemedicine as one aspect of digital health, but we know there's many other parts of informatics and things. So tell us a little bit about how fellows can get involved if they want to learn more and what an informatics fellowship looks like.
Yeah, thanks for the question. So there are the good news and bad news about informatics is it is a collection of lots of different disciplines in one, which can make it feel kind of confusing, but it also means that there are so many different career paths you can take. And there are now informatics fellowships and training programs that are typically 2 years. I think now there are some places where they can do a 1-year add-on on top of another ACGME fellowship. And those prepare you to be board certified in clinical informatics. Informatics can be a little bit of data science, a little bit of analytics, a little bit of clinical research, a little bit of culture and change management, a little bit of leadership, a little bit of design and user interface. And everybody within informatics has a slightly different flavor to what their practice is. And I think for what, something that Bob said in the last session, I think really resonated, which is diabetes is a window to healthcare. And so anything you do in diabetes becomes an opportunity to say, this is a template, or this applies to so many other places in healthcare. And so I think it's the same thing in informatics, where you can have the opportunity to either be an endocrinologist in there are lots of people now who are becoming endocrinologists that work in a digital health company. So you are a clinical endocrinologist, but you're practicing largely via digital means, working at a company like Livongo Teladoc or Omada Health or Onduo and other companies like that. You can become a product designer or a product developer where you are starting a company and you're really building a core product. You can become a chief medical informatics officer where you're really responsible for the electronic health record and all of the clinical information systems within a health system. You can become a leader within your diabetes practice or your endocrine division in utilizing informatics tools for better clinical care and quality improvement. You can become a clinical researcher who excels at pulling data out of electronic systems and doing clinical research on it. So there are, I think, what's exciting about it is that there are so many different paths that you can take. And I think, as I said, I think in the coming years, there's gonna be more and more opportunities across this space.
Fantastic, thank you. And that's a good transition to discussing clinical research with Dr. McGill as well. You have this wealth of clinical trial experience. One of the challenges for fellows is that clinical trials are often, require more time than fellows have during their training. And so what are some ways you've involved your fellows, in clinical trial experiences during their training?
Yeah. Well, we'd like them to see, feel, touch everything.
Yes.
And we have fellows that some take a hold of the trial and really become managers of that trial. And then we have fellows who, will see patients and learn the trial and learn about the trial. What I would suggest is, if you have an opportunity, sometimes you can even limit your time involvement. You can see a few of the patients. You can be helpful in a lot of ways. Get a hold of the protocol and look at it carefully. You need to understand what goes into a clinical trial protocol in case you ever want to write one, in case you ever want to think about doing something on your own. You need to read and catalog a couple either investigator initiated or NIH funded or industry funded protocols, so that you understand what it's about. So I think there are ways to get good experience without an enormous amount of time, and being afraid of, I don't have time for this, I don't have time for that, okay, well, I don't know what to tell you. You've missed out on high value experiences that may or may not have taken that much time. And, we spend so much time and focus on teaching the intricacies of lipid metabolism and pituitary function and diabetes and all of its forms and treatments and drugs and testing, and that people get the feeling that's all there is. I mean, it's a very blindered situation. That's all I need to know. And then something funny happened to me on the way to the forum. Somebody asked me to edit a book on atypical diabetes, but all kinds of other forms of diabetes. Really made me think, it's like I don't know enough about these. And now we're doing this atypical diabetes grant. So you need to take advantage of small opportunities and use them as bricks. You got to have bricks. And if all of your bricks are learning about, diabetes antibodies or something, you don't have you'll have medical knowledge, you'll pass tests, but you won't have very many bricks.
Thank you. And Dr. Duran, that, regardless of whether you're doing clinical research or a busy clinical practice and serving on clinical improvement committees and teams, how do you balance, and stay, you mentioned, being the best endocrinologist helps you at home. How do you balance all these demands and stay on schedule and on time?
Right. So I've eliminated the word balance from my vocabulary because as sort of spoke about earlier as well, I do think of life as synergy and integration. So, when we use the term balance, there's this notion that something is competing for another thing. And if you don't do one thing, it's taking away from the other thing. And so part of what I think helps keep my energy level and my passion alive through, the years is knowing that everything is feeding one thing. It's all integrated. In terms of, practical matters, get clinic, because as an endocrinologist, if you go into community practice, you will have a huge productivity pressure to see, complicated patients within 20 minutes, 8 to 5, Monday through Friday. That's close to 100 patients a week. And we've got a time crunch to do a lot of care in a short amount of time. And it just seems like it's getting shorter and shorter and shorter. So practical tips for staying on schedule in these high demand productivity markets, I would say, is it's going to come down to one, delegating. This is something I didn't learn as a fellow. I thought I had to do everything on my own. I was a perfectionist. If I couldn't do it, then it wasn't going to be done as well. And I didn't really have help to hand off tasks to. When you're out of fellowship, you're going to be, your number one priority is coming up with a care plan for your patients, doing high level work, and a lot of tasks like returning phone calls, mailing letters, any sort of administrative task. You use your medical assistant, use your office staff, delegate. And that works at home too. I delegate to my husband and family members. I even delegate to my 6-year-old child. you put your shoes on. So that's huge. We're not taught that as fellows. We're not taught that in medical school. We're taught to do everything on our own. So I believe delegation is huge. Start practicing that today. And then I would also say, keeping on schedule, you got to stay focused. So maybe with the complicated patient who has multiple problems, focus on one high impact health issue, address that, and then get the patient in for a follow-up visit. And this is sort of how we've got to do it. Utilize technology. Big thanks to Erin, who, brought out Tidepool and is bringing in the technology, which is making telehealth a lot easier, especially for the care of patients with type 1 diabetes. This is all, such an improvement from when I started practicing back in 2013. And so use technology as your friend. That helps keep you on schedule too.
I really love that concept of synergy, and I can see some of our fellows are loving that as well. I think a lot of this, again, is boils down to speaking up for yourself, delegating, and seeing where you can, help yourself, help others.
Yeah, and I see someone in the chat box commented about how balance makes that person feel guilty. This is so true. I can tell you. And the guilt is heavy. It weighs you down. I think as physicians, we have invested so many years in developing our minds and our talent. We need to keep light. We can't let the guilt get us heavy, because what happens then is we lose our creativity. And when that creativity goes, we cannot innovate. We cannot do the research. We cannot create. We cannot, ask those really important questions that really help propel our field forward. So let go of the guilt, work on integration, work on synergy, delegate, keep your mind light, stay in flow.
It is really disappointing that we're actually already at the end of this session. We could easily talk with each of you for an hour and still have more to ask. So I want to thank you so much to our panelists for showing us that you can have synergy, you can create your own path, and that there are multiple different pathways to doing diabetes care. I know we have a nice question for Dr. Neinstein as well. Unfortunately, I think just in needing to move forward, I'm going to ask if you wouldn't mind making a brief comment here. We can go over just a minute or so. I think this is an important question. Any other questions? So we might do by chat. And I want to thank you all so much for taking time out of your Friday afternoons to be with us.
Thanks. So let's see, I'll try to be quick. I think one is definitely feel free to explore because there are a lot of opportunities out there, and a lot of these companies are looking for specialty help and advice in diabetes. I think two is be careful and make sure you are advocating for yourself and have good advice from someone who either knows what they're doing or a lawyer, because you do want to be careful about making sure you don't get taken advantage of. There are a lot of startup companies that can sound very exciting, and it is easy to get taken advantage of if you're not careful. And I think the third piece of advice would be to, again, I think about what you want the future to look like rather than looking for what a role might have been 5 years ago. The future is changing very fast. And so think about where you want to be in 5 years and advocate and look for opportunities to develop into where that's going.
Thank you so much. And I think that translates to some of the clinical research as well, sort of, starting with your long-term plan. We'll now be transitioning to the final session of sessions of today's programs. I'm really happy to introduce today's panelists, two professionals bringing unique perspective to our discussions about basic clinical, population, outcomes, or implementation research. I'll begin by introducing Dr. Desmond Schatz. Dr. Schatz is professor and interim research an interim chair of pediatrics, medical director of the Diabetes Institute, and director of the Clinical Research Center within the CTSI at the University of Florida in Gainesville. Dr. Schatz has been involved in type 1 diabetes research since the mid-1980s and has published over 360 manuscripts, the majority related to the prediction, natural history, genetics, immunopathogenesis, and prevention of the disease, as well as the management of children and adolescents with type 1 diabetes. He's the principal investigator on several NIH awards. Dr. Schatz recently received the 2028 Alan J. Garber, MD, PhD, Lectureship Award, and was the 2020 recipient of the University College of Medicine Lifetime Achievement Award for Distinguished Service in Patient Care, Education, Research, and Leadership. We also have with us today Dr. Janice Wang. Dr. Wang is an endocrinologist and assistant professor in the Division of Endocrinology at the Yale School of Medicine. She received her fellowship training in endocrinology and metabolism at Massachusetts General Hospital. Dr. Wang's academic interests are at the intersection of metabolism, neuroscience, and imaging. Her research focuses on using advanced brain imaging modalities such as functional MRI and magnetic resonance spectroscopy, coupled with classic investigative techniques in metabolism to understand the effects of diabetes and obesity on the brain. Her research has been supported by the National Institutes of Health, the Yale Diabetes Research Center, the Endocrine Fellows Foundation, and the American Diabetes Association. Dr. Wang is the recipient of several awards for her research, including the Marilyn Fishman Award for Diabetes Research, the Metabolism Junior Investigator Award, as well as a Yale Center for Clinical Investigation Junior Faculty Scholars Award. Welcome, Dr. Schatz and Wang.
It's nice to be here. Thank you.
Thank you for having us.
Thank So much for joining us, and I want to encourage the participation again of the fellows. And so please, either raise your hand or if you want to just put questions into the chat. But let's go ahead and get started a little bit. And I'd love to hear each of you tell us a little bit about your own research beginnings and how you got started.
Yeah, I will start, and then we can tag team with Janice. But I think my own interest in clinical research was sparked at my very first American Diabetes Association scientific sessions meeting in the mid-1980s. And I was a fellow, and my abstract on really the natural history of islet autoantibodies in type 1 diabetes had been accepted for an oral presentation. And honestly, I remember it as though it was yesterday. I was terrified. I had to remake the slides on multiple occasions because this was before PowerPoint. And I practiced it over and over again. And somehow I survived. And I think that over the years, I have been very fortunate to be the recipient of a wonderful bench to bedside group of physicians and scientists at the University of Florida, which I think, by the way, is key to your success, which is teamwork. And I think I'll just pass that on to Janice.
Yeah, so thank you. And first of all, it's an honor for me to be here to be talking to you all. And I have a very similar story. I mean, you all are endocrinologists, so you must love physiology. And I think if you love physiology, then it almost becomes a natural thing when you start to question, why do things work this way? Why do things communicate the way they do? And so it just became a very natural thing to want to study something a little bit deeper. And pursue, sort of physiology-based mechanistic research, which is what I'm really interested in doing. And there's no better field, I think, than endocrinology, and especially diabetes, for doing that. And so, we wanted to keep our own personal intros a little short so that we could open it up for a lot of questions and to get into the details of, what you guys are thinking about and wondering about.
Yes, thank you so much for that point. This is really this is geared for you all as the audience, and so I'd love you to help us drive the conversation. I'm happy to participate in that as well, but please do ask your questions about. There's all sorts of various things, and so one of the ways I'll get started is Dr. Schatz, tell us a little bit about how the ADA helped you develop into a physician scientist.
So, there has always been a paucity, there is a paucity of physician scientists. There's a dramatic need. There's a dramatic need for physicians, for scientists, for MDs, for MD PhDs, and particularly for women, where we're really less than a quarter of the workforce, the scientific workforce, are women in every area. But the ADA has really encouraged me. I got my first grant from the American Diabetes Association. It was a postdoctoral fellowship, and with that award, I got involved with the American Diabetes Association and really, developed not only the research, but got involved in the community, got involved in advocacy, got involved in committees. And really, the American Diabetes Association has played such an important role in my own career because it's helped me develop not only as a physician scientist, but also as a physician, as someone who cares, someone for the greater good, not just for patients. Yes, I do research, but it's also for the community. And ultimately, the focus of the American Diabetes is to do research to prevent and cure diabetes, but ultimately to improve the lives of all patients with diabetes. And I want to encourage you, not only at the level of a physician, as a scientist, but also at the level of who you are, to become involved in the ADA to ultimately drive the mission.
Thank you so much. And actually, one opportunity, again, in this virtual format, it's a little harder to get to know each other for the fellows. So I'd love to hear about what research projects you're working on during your fellowship. And so maybe just a one-liner about the topic you're working on in the chat would be really nice. And that might also help drive some of our discussion. I really appreciate that you mentioned the women. I'm a fellowship program director. And so, endocrine I'm also on the Women in Medicine Committee at the university. And we typically have the reverse problem in endocrinology historically, where we've had many more women than men applicants. And so I haven't had that issue, but in our science, as you mentioned, we really do need more, women researchers. And Dr. Wang, this is something you're particularly passionate about. And so can you tell us about some of the benefits and challenges of balancing a scientific career and home and family life? This doesn't, of course, apply only to women, but I know this is a topic you're particularly interested in.
Yeah, absolutely. No, I'm so passionate about this because I think when I was just starting off as an endocrine fellow, to be perfectly honest, I didn't know 100% if I wanted to pursue a career in research, even though I love physiology and I love science and I loved research. But the word on the street was that, oh, like funding is terrible. Like, you're just going to be slaving away and, everyone's like dropping out. And so it was really a little bit intimidating. And, you have this vision of like having to, be there at 6 a.m. and being in your wet lab bench laboratory until 8 p.m. at night. You can't see your children. And so it was, it's a little intimidating to think about it that way. But I guess what I can say as someone who is pretty junior, I'm fifth year into my assistant professor. So I'm, about there. I just finished my K award. I've been very fortunate to have received some funding from the ADA as well as from the NIH with 2 R01s now. And I can tell you all that if you're worried about that, a career in research is actually such a wonderful thing in terms of wanting to also have a family and to have a balanced life, because even though you have to work really hard, you have so much autonomy. You have so much control over how you want to structure your day. And so if I need to take a couple hours off and, go read to my kids at school, I can do that. Because I run my own lab and I can organize my experiments the way they need to be. And so that flexibility has actually been a really wonderful thing. And, I would also say that, and this is maybe not so much in particular to being a woman and having family and things like that, but there's something really wonderful about having every day being a little bit different. You get to use all sorts of skills that beyond just, seeing patients and things like that. And you're always growing. And so, I found it to be very, very rewarding. And, my kids know that I'm a scientist and I'm a doctor, and they really like that. They like to hear about the science that I'm doing. I try to explain the experiments and they have questions at the dinner table. And so it's a very rewarding thing. And so if that's one thing I can share with you all is, and I can talk about this for hours, but I'm going to stop, is that it is a really great life to have. It's hard work, but any field is hard work if you want to do a good job.
Well, congratulations on your R01s. It's very, very nice accomplishment to hear about, at your relatively now early to mid stage. So you mentioned funding, and I know that this is something that is sort of what is perceived as a barrier by some fellows, is the concern, how will they fund their careers and their research grants? And it can also be somewhat overwhelming. Where do you go to get grants? There's so many different places. And so, Dr. Schatz, what are your, what's your advice on this?
So I think that really within the last few years, the NIH, the American Diabetes Association, with its focus on young investigators, Juvenile Diabetes Research Foundation, and then other organizations, including the Helmsley Trust, have really, I think, rallied to address some of these issues. And some of these include loan forgiveness programs. There's more clinical research, that developmental awards. There's really now adequate representation of clinical researchers on review panels for clinical research grants, and also having been on the other side, attempting to streamline, standardize, and simplify the regulatory requirements. But I think if we'll get to this in a while, what are the things that you're going to hear that's going to make you successful? And I think we'll get to that perhaps as the next question, after certainly we hear from Janet if she wants to add to that.
Yeah, I was going to add to say that, it always, at least in my experience, all those places that Dr. Schatz mentioned are great places to look. And then also at your own institutions, oftentimes all you need is a little tiny bit of pilot. Like, don't think that you need a huge amount of money or whatnot. Even a little bit is just enough to get started. And if you start to collect a couple of pilots here and there, then all of a sudden, then that parlays into, foundation or small NIA, and so I was very fortunate. That's exactly what I did. I had, one or two very, very small, like less than $1,000 from my institution, and then was able to do a little bit, and then ultimately, did receive some funding from the ADA, which really jump started everything. And so just keep an open mind and don't look down on the small sums. Those pilot funds are there for a reason.
Absolutely. And I'm looking at the chat, and it's really lovely to see the sort of diversity of interests that are very well covered in this group. I wish we had time to go through each of these, but we see basic research, community research, translational, clinical trials in both adult and pediatrics. And so our panelists, if you want to comment on anything in particular, but otherwise, I'd like to welcome Dr. Schatz back to your question that you were mentioning before.
So I hope we get to there's so much to talk about. There's just not enough time. But the title was basic clinical outcome or implementation research, population research, and hopefully I can show you a slide if we get to that. But most importantly, you're asking about what it's going to take to be successful. And you've already heard about mentors. And I just want to emphasize that you guys need to choose an environment where you have accomplished mentors and that there's really, the atmosphere is a buzz. And you want to get a research team where it's not just to get funding, but really that you want to confront these problems of mutual interest and that will share your ideas, share the resources, and then most importantly for all of you young people, which is going to lead to, publishing. And again, I want to always challenge you. Something that I've done and been encouraged to do and want to encourage you to do is to challenge, the status quo. Always challenge it, and a little skepticism. Do it in the right way. I mean, don't be discouraged also if the questions or the data leads to dead ends, and sometimes you've got to be satisfied with the null hypothesis. And when you're satisfied with the null hypothesis, then maybe you'll get onto a new path and a new road. But I will always say you've got to aim high and you've got to persevere. And, my son once said to me, and it's not a new saying, but an old saying that, that you're going to miss 100% of the shots, that you don't take on a basketball court. So just be patient. Don't get despondent. Never despair if you get a rejected manuscript or a grant. But I think that there is such opportunity ahead as we enter so many of the fields, which if we've got time, we can address.
Well, let's go ahead and address your slide. If I'm going to ask our producer, Gil, if you wouldn't mind pulling that up, and then we can ask Dr. Wang some specifics as well.
Okay, I just really could take a long time to do this, but really want everybody to sort of see it and start off on the left-hand side with basic science discovery. And that's really where it starts. New ideas, fundamental theories, unanswered question, investigation into something that probably doesn't make a lot of sense. But that's really where it starts. And for some of you, that's where you're going to go into the basic science. But then you're going to go through what the NIH has just classified as T1, T2, T3, and T4 research. And I just want to sort of summarize briefly T1. And again, there's opportunities for all of you at every single level. T1 is phase 1, phase 2 clinical trials, or really observational studies. And the question that's asked under T1 is what works under control conditions, because we want to translate from mouse to human and then to the bedside, which is really clinical efficacy. And so then that gets to phase 3 trials. And, yes, there's systematic reviews, evidence-based guidelines, and that gets into translation to patients, T2, what works in the real world. And then you're trying to work out clinical effectiveness, which then gets into T3, which are really implementation and dissemination. And you're asking the question, can we change a practice? And then we get to what I would say is population health, and then translation to a population. Now, I think there's going to be much further, because really what population health leads to is really implementation research. And what you're going to hear about, which you're all going to be part of for the future, is really precision medicine. And that's, again, such an area. We've entered the omics field. We're understanding so much more about the disease. We're translating it, into human studies. And really precision medicine is working with populations that will be affected by an intervention rather than choosing, which is studies, like we often do in phase 3, where we choose the patients. They're not always population based. So we really are going to need to take it certainly into the population, into the context. And really, I think that you stand at the critical translation of these new and emerging data that's coming from genomic, proteomic, metabolomic, transcriptomic research, because you'll know the patients. And even though I don't understand all this big data that's coming along now, but you will be able to work effectively with those at the bench, working with those in clinical trials, and then translate it, hopefully, into patients and ultimately into precision medicine.
Thank you. And Dr. Wang, can you tell us a little bit, in particular, your knowledge and experience in mechanistic human research, and how in diabetes that's particularly important?
Oh, sure. Before I go into that, though, I want to just build on what Dr. Schatz was saying with that slide. And, as I'm looking in the chat, I'm seeing all these awesome topics that you guys are working on. And, and what I would say is, Dr. Schatz had said, find a place where things are buzzing, right? And so you need to be you've got these great topics, are all really important topics. And, assess your landscape and see what are the areas that your institution or your microenvironment are really good at, and then try to see how you can fit your clinical question or your research question into this sort of framework that in this slide here. And then and I would say that sometimes when you're following the question, you don't have to always stay in one particular box. You're kind of shifting a little bit, depending on where the scientific question is taking you, and building collaborations with people who can help you and support you. Is really, I think, where the new stuff comes from, and we can really take your science to a novel direction. And for me personally, I also have a particular soft spot in my heart for mechanistic human research, because I think it's particularly relevant in diabetes and obesity work. And that's sort of, I think, where the T1 box would be, where you really want to, show so many exciting findings that we show in mice or rats or things like that don't quite translate to humans. And so being able to perform or conduct human studies, but where you really rigorously study like smaller groups of people, really deeply understand their physiology, sometimes by doing some of the classic metabolic techniques like the hyperinsulinemic clamp or even OGTTs or mixed meal tests or frequent sampling tests. Those type of tools, I think, still have a really important role in helping us understand, because we still actually don't know a lot about the physiology. We know a ton, but there's still a lot that we don't know. So that's where I would say. And then the other thing I would say is that in my own lab, I started off as doing like much more clinical efficacy work, and then have moved towards more mechanistic human work. And then I've gotten to a point sometimes in my research where I'm like, oh, I can't do this in a human, but I really want to know, a little bit deeper. And so, so then I partnered with some more basic science researchers and collaborate with them. And then we kind of take the human studies a little bit deeper in that direction. So all this to say that, I think this slide is a great framework that you can use actually to help think about your strategy for how you're going to attack your scientific question.
Thank you. And I think I really enjoy, can we keep the slide up for just one more moment, please? I think one of the things that our fellows sometimes struggle with is wanting to have the perfect lab, the perfect mentor that's going to answer exactly the question that they have. But what this highlights is how important methodology is in fellowship too. And not have the exact mentor, but as Dr. Wang mentioned, also you may partner and just learning these different tools that you have and how you might go between T1, T2 can be so important. And so, what other comments do you all have in your experience from training? Any pearls for going in when you don't have the perfect scenario for your lab or for your study?
I can start there because I'm still, I just transitioned to independence. So I've been very lucky that I actually have had wonderful mentors, but I would stress that that's mentor with an S. I have teams of, sorry about that. I have teams of mentors actually, because there's not one perfect, in a way, like mentor that can help you with everything actually. And so I really stress that. So I have, I have mentors that aren't even in endocrinology actually, that just kind of help me talk through life related things too, like how work-life balance and, academia and things like that. But the other thing I really wanted to stress is that, and this took me a while to learn, which is that when I first started, I went into the lab thinking, I really want to study this question. I think this question is the awesomest question, and I want to do it this way. And that really wasn't the strength of the lab. That really wasn't even the strength of the department. And I just found myself like butting, like just hitting dead ends. And it wasn't, I'd set up all these meetings. Everyone would be super nice and be like, I think this is great. This is a great idea. I wish I could help you. And it wasn't because people didn't want to help. It's because that they that really wasn't in line with what they were doing, and everyone's busy. So as a pretty junior person, I would say one thing that I realized that really helped me is finding ways that you can align your interests to also help the mentor's overall research program as well. And so it doesn't mean you're doing what that mentor is doing, but you're helping further their questions as well as furthering your own. And I've found that to be a very effective sort of alignment where the wind is blowing in the same direction.
You need to join teams, teams who have a proven record, teams who are publishing, teams who have active grants. It's not to say that you're not going to be successful on your own, but really it's very helpful because some things, as I said, end up in a dead end. And, if you've got lots of other people or people who are going to take you under their wing, they're going to guide you, I think it is so important at this stage of your career. There are obviously sessions today devoted to mentoring and choosing a mentor. And I think that what Janice has said is absolutely right. One person can't be everything to everyone. One thinks about a spouse, you think that a spouse can hopefully be everything to everyone, or your friendships can be everything to everyone. But I think, we've got different friends, and different friends serve different purposes. And I think that it's the same here. You do need people. A true mentor is an involvement in your personal as well as professional life. And I think that is very important, that you have people who care about you, who are looking out for you and want you to be successful.
Thank you. And that's pretty universal advice. If for those who are not envisioning a research career, I think that's excellent advice for a clinical, having senior mentors who are advocates for your practice environment is very helpful too. I wish we had more time. There's so many more questions we have, but I want to leave our fellows with pearls from your experience. And so maybe in our closing minute or two, could we ask each of you to provide us with any final thoughts or any advice you wish someone had given you at the beginning of your research careers?
Work hard, be patient, persevere, and also remember that a satisfying career is really what you're seeking. And Janet has talked a little bit about this, and a career in science hardly seems to be the first choice. And you think about maybe management, information technology, finance. Yeah, they may be more lucrative, and they may be more fulfilling in terms of material gain. But I think more than ever, you need a satisfying career. And those are some, things that I was presented with, and I would perhaps close with those similar remarks.
Thank you.
Yeah, I would just second that. I think I really consider a career in research in any way, because it's a very rich life from an intellectual, emotional perspective. It's very rich. And then I would also second the patience. And one thing that has always stuck with me, I was in one of these talks, and someone was saying that the only corollary with success in research in terms of maintaining a lengthy career is the persistence in applying for funding and dealing with rejection, and but persisting with following the question. And so be patient and don't give up. It's a wonderful career.
Thank you so much. Thank you to both of you for sharing time with us and pearls from your experience. And we hope that many of our fellows will have successful research careers following in yours and others' footsteps. The scientific sessions is a great way to see some of the see all of those phases, work being done across the phases that we learned about today. So thank you again for your time. And we'll move on to our final session today. It's my pleasure to introduce Dr. Enrique Caballero, an endocrinologist and clinical investigator. He's the director of Latino Diabetes Health in the Division of Endocrinology, and an associate scientist in the Division of Global Health Equity at the Brigham and Women's Hospital. Dr. Caballero is also director of International Innovation Programs in the Office for External Education, and the Director of Diabetes Education in the Postgraduate Medical Education Department at Harvard Medical School, where he leads the development of education programs benefiting the healthcare professionals and patients around the world. Dr. Caballero also serves as the chair of the ADA's National Health Disparities Committee, and he'll be talking to us today about health equity in diabetes science and healthcare. Welcome, Dr. Caballero.
Thank you very much for the invitation. I really enjoy this type of activities, and thank you all, the fellows, for being here in this activity. I'm the last one in the program, which is always a challenge, but hopefully you'll find some important and useful information from what we discuss today.
Thank you so much, and for joining us. And this is a time, in a way, I'm sort of, last but not least, this is a topic that we began with Dr. Gabay. This is an area that so many of our fellows are interested in and engaged in. And so, let's talk a little bit about how the pandemic highlighted and really, I mean, we know about the disparities, but we really saw them in the spotlight in the pandemic. What were your experiences there?
Yes, well, I think that what happened with the pandemic is that we all confirmed something that we knew before, but I think that now is at the forefront of the news and obviously for everybody to discuss, and that is that there are populations that have been affected in a more severe way than others, and that is clearly people with chronic diseases like diabetes and others, but within those individuals, clearly those that belong to racial and ethnic minorities, people with lower socioeconomic levels, have been affected. And there's a lot of different reasons for that. I think that part of it is we have known for a long time that controlling diabetes and chronic conditions has been more difficult in some of these populations. But also when it comes to asking them to stay at home, to follow a better meal plan, to be in places where there's not a high risk of getting the disease, et cetera. And then you think about the way of life for many of these individuals where they don't have the luxury of staying at home, that they can follow some of these recommendations. It's not that they don't want to, they just can't sometimes. And then when you ask them to be physically distant from others, when they live in houses, when there's a large group and they live in places where they can't actually separate physically from others very easily, then you understand that there's a lot of reasons why the pandemic has affected many people. And I'm not talking obviously just about our country here, but throughout the world, that's the experience everywhere. So we have known for many years about the fact that there are populations that are affected more, so these disparities that exist. But the other concept I think it's important to remember is inequities. So disparities refers to, let's say, when you find that the prevalence of a disease is more or is higher in a group compared to others. That's a disparity. But there's a reason for that. And the reason is that there are probably underlying conditions that explain why a group has more problems than another. That's where the inequity or the inequities come into place. And we have to admit that in our country, as it happens in many areas around the world, opportunities are not offered in the same way. Not everybody has the same opportunity, and these are the so-called social determinants of health. And that's an area that I would truly invite everyone in the audience today to explore. It doesn't really matter what you're going to be doing in the future in terms of research, in terms of clinical work. You will encounter disparities. You will encounter inequities. And that's an area that I think is very important to embrace. For example, I can share how I started my career in the sense that probably just like most of you, the fellows, I was so excited about the scientific part of medicine. And I am originally from Mexico. I came to the US to do my training. And I was very fortunate to stay here in Boston in the Harvard system. So I worked initially at the Joslin Diabetes Center, which is, of course, a great place. And I was doing research there initially on endothelial dysfunction, diabetes, cardiovascular disease. I actually joined the diabetes prevention program when it started more than 20 years ago. So it was a fantastic way to start my career in research by looking at the metabolic syndrome and all these important issues. But then over the years, what I found is, because I was also doing clinical work, is that I was not having the impact that I thought that I would have with my patients. And that was a puzzle to me because I said, well, I don't think I'm really a bad clinician, but most of my patients are not achieving goals. There's something going on here. And that truly opened my eyes because even though I was at a great center, the impact that we were having was not really the the greatest that we could have aimed at. And I guess this is not just my experience. I think that as you go along, you find that you have to pay attention to other aspects of diabetes care and research. And that's the whole area of all the social, the cultural, the psychological factors that are part of any individual that we come across in our lives. And again, we're talking about patients and people that participate in research, but that applies to life in general. So over the years, what I have embraced is the fact that even though I continue to love science and I love it and I continue to be involved in many different activities, that's great. But that's not enough. If you really want to have an impact on patients and your patient population, again, it doesn't matter where you are going to practice or where you're going to be, whether you're staying here in the US or you're traveling abroad and do work and research, you're going to encounter that there are all these factors that are important to consider as you move forward in your career. And I think that that will make us even more complete, more comprehensive as individuals in our own lives, but also in the way that we provide care to other people. So paying attention to those things is important. Now, I have to say that it's a challenge because even though we may all say, yes, I think that's true, it's an area that we need to pay attention to, it is not easy. We are not trained formally to address and to assess psychological, social, cultural issues in our patients. It's easier to stay in our comfort zone, and that is the medical side of things. You know, we love discussing cases and the pathophysiology and treatments, and that's great. But we often forget about all the other aspects, and that's not easy to incorporate into our clinical activities or research activities. But we must pay attention to that. I'm happy to say that over the years, and I have been a witness to that and participating somehow in my own world, is that medical schools, training programs, medical education activities are now incorporating more formal training about all these different aspects as they relate to diabetes care, diabetes research. And I would suggest to everybody in the audience to explore some of these opportunities in your own hospital, in your own clinic, in your own community, about how is it that you could learn more about how to incorporate all these important aspects in clinical care and research. So I think that we're moving in the right direction, but it's a slow process. So coming back to the question, I think that the pandemic has just made it very clear that these are things that we need to pay attention to as we move forward, and not to forget about how crucial these are in determining population health.
Thank you so much. I mean, this is for highlighting that this is something that affects all of us. Those who will make a career out of this important area, and those who will experience it in their day-to-day practice, as we all do. And so, let's we'll go on both spectrums. We'll start with everybody, because everybody will see patients with dealing with inequities, whether that be in access to technologies or medications or food, as you mentioned. What are tools that our fellows and clinicians can use to do surveys? A lot of it comes out in a thorough and thoughtful interview, but are there any tools, whether that be your general recommendations or from the ADA on addressing disparities in the clinical encounter?
Yeah, well, there's fortunately several sources of very good information that people can look at. Obviously, the American Diabetes Association is a great way to start. I'm very fortunate to be chairing right now our committee on healthcare disparities. So we have really worked very hard for several years now in trying to develop different type of activities and materials and information. So you can check on that at the ADA level. But I am sure that also your clinics, your hospitals may be doing work in this area. And the reason is that it is not necessarily a mandate now, but it is something that most institutions have embraced. And there's a very good reason for that. Now that we're moving into this sort of value-based care in which we're trying to improve outcomes in our patients, and then you need to demonstrate as an institution that A1C levels are really better in your patients compared to a few years ago, that the blood pressure, that weight, and that the standards of care are being applied, et cetera, because then you get more money as an institution. You're paid based on your performance. And part of that also has opened the door for people to consider that the only way to truly have an impact in a patient population is by embracing all these things that I'm discussing right now. So if you only focus on the medical side, you're going to have an impact, but it's not going to be as good as if you consider other factors in your practice. So it is good for you. It is good, of course, for your patients, but it's good for you. It's good for your institution if you do something like that. Now, the best way would be, because honestly, I recognize that we're very busy. We don't have a lot of time when we interact with patients. So if we think about, well, how much time it takes just to consider the blood sugars and look at the CGM readings and the blood pressure and all that, of course, 20, 30, 50 minutes go by very quickly. We don't have time to address other things. So the only way to go, in my mind, is to find a way to embed all these factors into routine clinical evaluations, and ideally to be part of electronic medical records. For example, where I work now, because as I said, I worked at the Johnson for many years, but I transitioned a few years ago to the Brigham and Women's Hospital. And I'm in charge of the Latino program within the hospital system. And then we have a lot of community health organizations that are affiliated with the Brigham and with the Mass General. So it's a big organization. And what we're trying to do is to implement some of these aspects of social medicine throughout the system. And the way that we have found that it's easier is if this becomes part of the electronic medical record, because that way you don't forget about asking all these things, because there are so many things that are going to distract you and that you, of course, need to concentrate on because they're important. But if there's something that reminds you, have you assessed transportation issues? Have you assessed food insecurity? Have you assessed emotional, psychological issues? Have you assessed, all these other factors that we may forget? I think that's important. Now, one thing, so that people don't panic about this, because I'm sure that people are saying, oh, Dr. Cabello, that sounds great, but you're making my life more difficult. Now I'm going to have a lot more work to do. Well, it depends how you coordinate that with your program and in your group, because you may actually not be the one to ask all these questions. Someone in your team may be the person to do that. So, for example, in our program, we have people that work in our social medicine group, and they're the ones that do all these surveys with the patient. So when they come to see me, I already have all that information. Now, of course, it depends on who you work with and what group you are participating in, but that's another possibility. But I think it is our responsibility as healthcare providers, as researchers, to pay attention to all these information. Now, one thing to say is we're not responsible for fixing the problems that we may encounter. I'm not saying if you find that someone is struggling with transportation, you should go and pick that person at her home to come and see you. No, that's not the point. But if you don't identify the problem, who is going to identify the issue? And we could not actually rely on what the patients are going to say to us, because many patients will not express openly their challenges unless you prompt them to do that, unless you elicit that conversation. And so it's important to be paying attention to all these different things. One example is the issue on, for example, depression and emotional distress that I have learned from many of my expert colleagues in this field. And depression seems to be the most frequently missed diagnosis in clinical practice. We just don't know how to address it. We don't know how to identify it. So there are tools. For example, we know that in order to identify major depression, you can ask just one single question that has been validated, and that is whether a patient has lost interest in their day-to-day activities in the last few days or weeks. If the person says, I don't feel like getting out of bed to go and pick up my children at school or do my activities, etc. I know we all may feel like that some days, but it's just probably one day, hopefully, but not every day. So if someone says something like that, imagine how inappropriate it is in that visit to say, well, what I would like you to do is now to take not one injection of insulin, but 3 or 4, and improve your meal plan and check your blood sugar more frequently it makes absolutely no sense. We need to, of course, identify all these other things that are more important for our patients. So things like that, I think, are important in terms of incorporating all these different things in clinical practice. I shared a couple of articles, and hopefully the fellows can get those. One is I created a few years a list that I call the A to Z list for the management of diabetes with a focus on culturally diverse populations. And what I did was that I assigned a factor to each of the letters of the alphabet. It took me some time to do that, but I found that there is actually information that validates the evaluation of each of these factors in clinical care in diabetes. So we can definitely share that. Or I don't know if I have an opportunity, I don't know if we have time, I can share quickly my screen if.
Yeah.
Oh, okay. Because maybe I can do that and then just show that very quickly. Maybe that would be a more graphic. Okay, let me see. All right. There we go. Okay. Can you see that slide?
We can see it. Thank you.
Okay, great. Well, so very quickly, so as an example in terms of practical recommendations, and I won't go through that in a lot of detail, but each of these factors, and I would ask everybody in the audience just to go through that list. How many of those factors do you evaluate in your clinical practice with your patients? Some I'm sure you do, but there's others that you probably don't do routinely. So for example, I talked about depression. Health literacy is another very important factor that has become more and more important in diabetes care. And there's tools, there are surveys that allow you to assess health literacy in 10, 15 minutes in a patient. And that will guide your efforts in how to tailor the education programs, even the conversation that you're having with that patient. So that's very important. Language, I don't have to tell you much about that, but obviously we live in a multicultural society. And recognizing that language could be a barrier for some patients, having the proper setting to do that. Now, if you speak other languages, that's great, but you don't have to. But if you have an interpreter or if you have a system that can help you with that. And the prescriptions, for example, which is a very common mistake that I see, they need to be written in the language that is preferred by the patient. There's been a lot of mistakes, and maybe on another opportunity we can talk about that people just don't follow the instructions correctly because they did not understand what was written in their prescription. Nutrition and food insecurity, one very important issue. People don't realize that at least 15%, if not more, of patients with diabetes in the country have food insecurity. And then we need to ask that because people sometimes may not be willing to disclose that information unless we ask them if that's an issue. And there's many other things, as you can see here, in terms of the quality of life, religion, obviously the socioeconomic status is important to be addressed, whether people are using technology or not, and how we could help, especially now. That's been another sort of learning point from the pandemic, that maybe the use of telemedicine could be actually something that we can incorporate in the future, hopefully, even after the pandemic is over. The fact that we may have unconscious biases as well, something to explore on our own, and asking the patient, about their own perceptions about the disease, about what's happening, and not just to come to an encounter telling them what to do, but to really listening to them. I think that's very important. I'm sorry, exercise. I couldn't find anything else for exercise for X, so I came up with that, but I know that's not the way you write it. But and then the patient-centered approach, which of course it is crucial. And then I ended up with Zip It because there's actually studies that have shown that clinicians are the ones that speak the most in all the encounters and not the patients. And that it takes only about 23 seconds in average for a clinician to interrupt a patient in a clinical encounter when the patient is trying to express all his or her concerns, etc. So we're not actually engaging in good, productive conversations and communication with our patients. We believe we are, but we are not. So there's a lot of areas of opportunity to improve in terms of how we establish that connection that collaboration with our patients, which will be crucial regardless, again, as I said, of what area of endocrinology or diabetes or wherever you're going to end up working in research or clinical care. I think that will be a very important aspect to consider.
This is such a nice and comprehensive assessment. And I think, one of the frustration is that especially junior, I think we get more used to this as we advance, but it is that you can't do anything about certain areas, as you mentioned, for example, transportation. But sometimes just by assessing things over and over in patients, you start to see patterns, and that helps you identify sort of systemic problems that then you can advocate for resources for. Just kind of looking at this, going to Alexander's comment. And bridging this into research, how do you make these systematic? And let's operate not with a center like Jocelyn, which is or where I'm lucky to practice. We now have even a social worker, but in smaller practices, how can we make these things more systematic? And then I'll transition that to my colleagues who are interested in getting into disparities and inequities research. How do we study these after we've systematized them?
Yeah, I think that there's a lot of research that is needed because what I said is that there is some evidence that many of these factors are important. They're associated with diabetes-related outcomes. There's no question about that. Now, are there any studies that demonstrate that if you do what I said in terms of, well, let's address all this together, let's do it better, can we demonstrate that outcomes are definitely improved? There's no such a research right now. I think that's where we need to go. There are, of course, efforts that have demonstrated that a particular strategy helps diabetes control. For example, I'm a fan of the shared medical appointments, the group medical visits, and I do that with my patients, and they work very well. And at the Brigham, we're now implementing this in a wider level. And there are studies that show that that works as a specific strategy. But when we look at everything that we need to do a lot more research in that area. But as I said earlier, and then just to answer the question about how to make it more systematic, I think that it starts with your own activity, with your own clinic, with your own hospital. And I would guarantee that almost all hospitals now are embracing this one way or another, because everybody believes that this is the right thing to do. This is the most important thing. Working in an area that you know is going to have an impact on your patients and the patient population as a whole is the right thing to do. It is an important area of medicine, a very important area of life. It's an area that I have to admit, not everybody is very interested in. When you go to, for example, the wonderful ADA scientific sessions every year, there's 2 lectures at the same time, one on the latest clinical trials in cardiovascular disease, and then another one on behavioral health and social aspects of care. I can guarantee that 95% of the people are going to be in the one on the clinical trials. And that's important. That's a fantastic, I love it. I may actually be there in some cases as well. But I think that we need, if we are really serious about improving diabetes care for all, and I am very glad that the ADA has truly been behind this effort for many years now, we need to consider all these other factors. And so I think that institutions are also supporting some of these activities as well. That's really great. But as I said, it needs to be part of the routine clinical evaluation. In research also, for example, if you are going to do research, most organizations and agencies like the NIH will ask you to demonstrate that you have efforts to include people from different backgrounds, from different socioeconomic levels, from different race and ethnicities, because that's an effort that, whatever we do needs to reflect the population that we serve. And in this country, we live in a multicultural society, and we need to help absolutely everybody. And I think that's just aligned with what we're discussing today about bringing all those opportunities to clinical and research work.
And I think as a bridge, I think one of the most important things you highlight is that we have these tremendous scientific advances that are presented at the keynote big presentations, but why we don't see these translate into significant improvements in A1C in the population is because of a lot of these inequities. And so this research really is, and not just the research, the practice is so important. And so we really are so grateful for the work you do and your colleagues. And I wish we had more time to discuss this. We're nearing the end now. Is there anything for those of our fellows who really want to make a career, or at least a small delve into this? Is there any advice that you have for them?
Yes, I would say that I heard the prior presentation, the final messages, and I totally agree. You need to work hard. You need to find a mentor. You need to be in the right place. I think all that is extremely important. But I would add that you need to be where your heart is. You need to do the work that is going to be rewarding for you. And that may or may not be the same that other people are doing. That may or may not be the one that is going to pay you the most. That may or may not be the one that is going to allow you to get a promotion faster, or that is going to allow you to publish more papers than other peers, etc. We live in a very competitive world. There's no question. But my sense of success is that everything that sometimes we strive for, and that is recognition, publications, papers and promotions and all that, that's totally secondary. It's great to have those things, but that's secondary in my mind. What really matters is that you are doing work that makes you feel proud, that you know that you're really doing the right thing and that you're helping as many people as you can, and then you're impacting their lives properly. So this may be a call for some of you in embracing some of these areas as you move forward in your clinical and in your research careers. But as I said, even if you don't do that full time, or that's not the area that you will focus, you will have to address these things one way or another, regardless of the area that you go into, because this is just part of our lives, and that's the part of the lives of all the people that are going to be taken care of. So I just wish you good luck. My best wishes for all of you in what you do, and if I can help anyone with more information, I'll be very happy to do that for sure.
Thank you so much. We really appreciate you sharing your knowledge, your passion, and your experience. It really shines, and I know that many of our fellows will take this to heart. I want to thank all of our presenters today, and all of you fellows. There are a lot of you who stuck it through, and I'm so impressed on a Friday afternoon. But you can see that there's a lot of heart and a lot of great wisdom from our colleagues here today. So I want to thank each of you for participating. I want to also thank our staff again for helping us put this program together, and the Leona Helmsley Charitable Trust for supporting us. This is our 8th year, and they continue to support us. As a reminder, you'll be receiving follow-up information on how you can take advantage of your free membership to the Professional ADA, and then the scientific sessions as well, which are going to be coming up in a few weeks. We hope you'll join us next Friday for our next Focus on Fellows program. We'll have another great lineup of sessions and workshops. And thank you so much again. We look forward to connecting with you soon. Have a wonderful weekend, everyone. Bye-bye.